Good morning. This is a rapid revision for tomorrow's chapter test, and I'll start by possible questions on multiple sclerosis. The first question, of course, you might be asked is, why is multiple sclerosis or MS considered an autoimmune disease? Of course, this is because the immune system considers the myelin sheath around the axon in myelinated neurons, considers it a foreign body, and therefore the immune system attacks it. And when the immune system attacks it, it first results in inflammation, and then this inflammation is followed by complete removal or degeneration of the myelin sheath, which we call demyelination. So the other possible question about this concept is, what are the effects of the immune system attacking the myelin sheath or attacking the myelinated neurons? The immediate effect of the attack of the immune system would be inflammation, but the late effect or the remote effect would be degeneration of the myelin sheath and demyelination. Of course, if the question is a rather longer question, then you should mention the effects of each of the first stage, which is inflammation, and then the second stage, which is demyelination. As for inflammation of the myelin sheath, it depends on the neuron that has been affected. Of course, you know that myelinated neurons are mostly motor neurons, but they can also be sensory neurons. So if the stage of inflammation involves a motor neuron, then definitely it will result in weakness of the muscle involved. And the same occurs when there is complete demyelination of the motor neuron, but the weakness will be more prominent, meaning that the muscle may be paralyzed. So inflammation of myelinated motor neurons results in weakness of the muscle and then maybe complete paralysis of the muscle. Why? Because in late stages, when the myelin sheath is completely removed, there will be slower transmission of the nerve impulse along the motor neuron. Why? Because, as you know, the myelin sheath improves the speed of transmission of the impulse along the motor neuron or along the myelinated neurons in general. And of course, if the myelin sheath is affected, especially when it is completely removed, this will result in slowing down of transmission and therefore in weakness of the muscle. In the sensory neuron, it's a bit different, meaning that in the motor neuron, it starts by weakness and then it ends up by more weakness or paralysis. But in the sensory neuron, if it in the early stages, the inflammation will result in symptoms like pain, for example, which is really like uncomfortable, unpleasant pain, because this is pain along a sensory neuron. So during inflammation, there will be symptoms that are related to inflammation of the sensory neuron or simply irritation of the sensory neuron, like pain, like a tingling sensation, for example. But later on, when there is complete demyelination or before complete demyelination, you might suffer from numbness, meaning that you feel that the limb is heavy and you feel that you don't perceive all sensations the same strength you used to do before, but at the end of the day, you will suffer from complete loss of sensation. Of course, and the next question would be, and it has been covered in the previous introduction, what's the relationship between multiple sclerosis and impulse transmission? Of course, when there is an autoimmune attack to the myelinated axon, then there will be affection of the myelin sheath, meaning that there will be a diminution in the function of the myelin sheath or complete removal. And as you know, because of the nodes of Ranvier between the myelin segments The presence of the myelin sheath helps rapid transmission of electric impulse along the neuron. And this is what we call saltatory conduction, because the electrons will jump from one node of Ranvier to another. Now, if I ever ask you about the factors that affect the symptoms in multiple sclerosis and the signs, of course, you know this very well. It depends upon which nerve is affected and upon the extent of the damage. For example, if I ask you to give examples of symptoms and signs of multiple sclerosis and how they are related to the nerve that has been affected, you might choose any sensory affection or any sensory damage, and you say that it is because of demyelination of a sensory neuron. For example, numbness. Numbness is due to loss of or complete anesthesia, for example, is one of the symptoms due to sensory loss. But you might have sensory irritation. So you might choose pain and tingling. But if you choose pain and tingling, you would say that this is because of inflammation of the nerve, not because of complete demyelination. What applies to pain and tingling applies to electric shock sensation, because it is due to irritation of the nerves. And I highly recommend that you review your comprehension passage, because it includes more and more information about examples of symptoms and signs and how they are related to the corresponding nerve. Again, this loss of vision is a sensory affection, double or blurry vision, because this is loss of vision is related to the optic nerve, as well as pain during movement of the eye globe. These two are related to involvement of the optic nerve in demyelination. But when we come to double vision or blurry vision, we start now talking about motor demyelination, because when you have double vision, this is because the extraocular muscles that move the eye are not synchronous with each other. They do not move at the same time. Similarly, if you say weakness in the muscle, this is due to demyelination of a motor nerve. And if you say slurred speech, of course, this is due to motor demyelination. Bladder function disturbances include both. Urinary incontinence might be due to sensory affection or due to motor affection. You might not be feeling that the urinary bladder is full, or you might not be capable of evacuating your urinary bladder, respectively. Fatigue and dizziness are related to all this. Dizziness is mostly due to affection of the neurons in the brain stem, especially in the medulla oblongata, that controls blood pressure, pulse, because the patient might be dizzy because of a low blood pressure and low cerebral perfusion with blood, or dizziness might be due to affection of the neurons in the cerebellum, because the cerebellum is related to equilibrium. Fatigue is related mainly to the pain that the patient encounters because of affection of the sensory nerve. Multiple sclerosis is characterized, just like any autoimmune disease, is characterized by remissions and exacerbations. And what do we mean by remission? Remission is a period of time when the symptoms are diminished, and exacerbation is a period of time when the symptoms are increased. When the symptoms are increased. And as you know, disease-modifying drugs try to prolong the periods of remissions and diminish the periods of exacerbations. How would we diagnose multiple sclerosis? Mainly by lumbar puncture and magnetic resonance imaging. Lumbar puncture, we withdraw a part of the cerebrospinal fluid from the cerebrospinal fluid, the cerebrospinal space or the subarachnoid space that lies around the spinal cord, and we analyze it. Usually, there is a certain glucose content, a certain protein content, and a certain white blood cell content, and it should not contain antibodies. In severe inflammation, you might see that there is an elevation of the white blood cell count and a diminution in the glucose level because of consumption of the glucose by the white blood cells and the pathogen, if any, but here we don't have pathogens. You might have an increase in proteins. In such a case, in case of multiple sclerosis, you might find an increase in immune cells, but mainly in lymphocytes. And you might find, of course, the autoantibodies that are formed by the autoantibodies that are formed by the immune system against the myelin sheath. The MRI, I might ask you about the scientific basis of magnetic resonance imaging. The scientific basis of magnetic resonance imaging is the use of a magnetic field to visualize the different parts of the brain and any pathology if present. And by the way, there is something I didn't mention in class, and that's not present on the slide. If you find that there is increased brightness of the white matter, this indicates inflammation. But if you find that there is dullness or darkness in a particular area of the white matter, this indicates demyelination, which indicates, of course, a later stage. The main drawback of magnetic resonance imaging is the magnetic field, meaning that if the person should put off or take off any like jewelry that's made of metal, and if the patient has already been exposed to a surgery and has a metallic plate or screws inside any body part, then these might be displaced by the attraction to the magnetic field, especially in the first 6 months. We sometimes use for imaging, for magnetic resonance imaging, we use a dye. We inject a dye before in order to better visualize the structures in the brain, and especially the cavities and the ventricles. But the main drawback of this is that the patient might be allergic and might suffer from an anaphylactic shock, which is a severe drop in blood pressure and slowing down of the heart rate resulting from an allergic reaction to the dye. And because this might affect the oxygen supply to the brain, this might be very injurious to the patient because he might end up by having a hemiplegia or paraplegia or quadriplegia according to the parts that have been affected in the brain, but mostly hemiplegia or cognitive losses. The CT scan or computerized access tomography is another way of visualizing, in which we visualize slices, very thin slices of the brain. But the problem is that in CT scan, you are exposed to a huge dose of X-ray, which is like at least 10 multiples of the dose of the normal dose of X-ray, which is already which is already like carcinogenic and helps appearance of cancer in patients who are genetically predisposed. Of course, as you know, there is no definite cure for multiple sclerosis. We give disease-modifying drugs just to prolong remissions and shorten exacerbations and diminish the intensity of the symptoms. The main treatment of multiple sclerosis is corticosteroid, and as you know, It's a steroid hormone secreted by the cortex of the suprarenal gland. And the main function of corticosteroid is to reduce inflammation and therefore to reduce and delay the process of demyelination. But cortisone has side effects. It elevates the blood pressure, it elevates the blood glucose level, and therefore it is contraindicated in hypertension and in diabetes. On the long run, cortisone causes insomnia or lack of sleep and depression. It causes mood swings in general. And of course, it results in fluid retention because of salt retention. So it might result in weight gain because of salt and water retention in the body. Plasma exchange or plasmapheresis. So what is plasmapheresis? It is a process of plasma exchange that is referred to in severe cases of multiple sclerosis that are not responsive to corticosteroids. What do we exchange? We actually take out the plasma of the patient and instead give an albumin solution. Why an albumin solution? To maintain the oncotic pressure of the blood constant, and the oncotic pressure is the ability of the blood to retain its water because of the presence of albumin. And I'll never ask you about the oncotic pressure, but it's just to explain why, especially albumin. So you remove the plasma of the patient from the blood and you replace it, of course, by another fluid that is very similar to plasma, that is an albumin solution. By doing this, by removing plasma, you have removed the antibodies that attack and cause destruction of the myelin sheath. In Alzheimer's disease, the most important point to notice is that Alzheimer's disease is a progressive degenerative disease of the brain. And by degeneration, we mean decline in function because of damage that occurs to the neurons, and it ends up by shrinking or atrophy of the brain size. As I told you before, after the age of 40, there is a gradual decline in the size of the brain, but usually when this occurs, and it is a physiological decline, they write in the report that the diminution in size is corresponding to age or is proportionate with age. But in Alzheimer's disease, it is disproportionate to age, meaning that if a patient who is 55 has Alzheimer's, severe Alzheimer's, then the size of the brain might be the size of an 80-year-old person. Alzheimer ends up by dementia, and dementia is a decline in cognitive functions, meaning anything that is related to understanding, like thinking, judgment, reasoning, making decisions, behavior, because it is related to cognition, of course, controlling your behavior and selecting the appropriate behavior is related to cognition, as well as your social skills. When all this is affected, of course, as well as memory, of course, and when all this is affected, of course, the patient cannot live alone and the patient cannot be left on his own to lead his life. What is the pathology inside the brain that results in Alzheimer? We have two pathological changes that occur. One occurs outside the neuron and the other occurs inside the neuron. The one that occurs outside the neuron is the accumulation of abnormal amyloid plaques. What are the amyloid plaques? They are abnormal proteins that deposit outside the neurons. Whereas on the other hand, there is another protein inside the neuron that might cause a problem. That protein is the tau protein. The tau protein is normally present inside the neurons. But the problem is when you have, and of course, the tau protein supports the skeletal fibers in the neuron. The skeletal fibers are elongated protein molecules, or the tubules. They are elongated tubular proteins that act like a scaffold for the brain cells and support the neuron from inside. This is normally present inside the brain. Every now and then, the tau proteins get phosphorylated, meaning that we add phosphate to them normally. But if they are excessively phosphorylated, they will entangle. They form what we call a tangle. So when the tau proteins become entangled, they are no more normal. They no more do their function to support the neurons, but they start together with the amyloid plaques that are outside the neuron, both together. The entangled tau inside and the amyloid plaques outside start diminishing the process of impulse transmission along the neuron, diminishing the transport of nutrients across the neuronal membrane, and diminishing the transport or transmission of electric impulses along the synapse. So, of course, if you have very slow synaptic transmission, then you will have very slow cerebration, meaning that you would have very slow brain function, including the cognitive functions. A very important question to answer is, why is it more frequent after the age of 65? Actually, you are genetically predisposed. So there is a genetic predisposition, but there are environmental factors. And these environmental factors help the formation of amyloid plaques and tau proteins. Between the age of 40 and the age of 65, even if you are genetically predisposed, the body has its own mechanisms of removing these amyloid plaques and tau proteins, meaning that they're all the time formed, but meanwhile, the rate of their removal is higher than the rate of their formation, so they do not affect you negatively. But after the age of 65, the rate of their deposition is higher than the rate of their removal. So the ability of the neuron to dispose of those abnormal proteins diminishes. Of course, from 1 to 7, this is the symptomatology that results from the pathology. So these are the results of diminished neuronal transmission, increased memory loss or amnesia, and of course, this is mainly for recent memories. And of course, inability to learn new things, problems with language, because Broca's area and Wernicke's area might be affected. The frontal lobe might be affected, so you might have difficulty organizing your ideas and thinking logically. The parietal lobe may be affected, so you might have difficulty with math skills and working with numbers. A shortened attention span, of course, is related to the limbic system and to the reticular activating system. How can we postpone Alzheimer's? By diminishing smoking. And first of all, why diminishing smoking? In order to improve the circulation of the brain, because nicotine and the toxic products in cigarettes and in all things that are smoked diminishes the cerebral perfusion or the blood flow to the brain cells. And of course, when you don't have enough oxygen, then the toxic products are deposited at a higher rate than they are removed. Similarly, exercising is important for the same reason. So stopping smoking and exercising are important because they improve the blood flow. Alcohol, because it's directly toxic to the brain. So if you stop alcohol, then you are diminishing the toxicity of alcohol on your brain. A healthy, balanced diet, of course, because of all the vitamins that are inside, and those vitamins act as cofactors and coenzymes mainly, they act as coenzymes for chemical reactions in the body. Epilepsy is a neurological disease that is characterized by frequent seizures. And seizures are, might be petit mal seizures or grand mal seizures, but grand mal seizures are essentially characterized by contractions of severe abnormal contractions of the muscles of the body. Seizures, whether they are minor seizures, like in petit mal epilepsy, or major seizures, like in grand mal epilepsy, they are bursts of increased electrical activity in the brain, and therefore they don't only result in abnormal muscular contraction, but they also result in negatively affecting how the brain functions. They negatively affect memory, they negatively affect cognitive functions, they negatively affect speech, but of course, during the attack. In between the attack, the patient might be completely normal. Of course, there is genetic predisposition to epilepsy. So, of course, there is a genetic predisposition, but there are other factors that might predispose to having epilepsy, meaning, but it's important, it's worth mentioning that many cases of epilepsy are cases where the cause is unidentifiable, there is no genetic predisposition, and none of the factors I'm going to mention now are present. For example, if you had previously had a stroke, or then around the damaged area of the stroke or the dead area of the brain, you will have nerve cells where there will be increased electrical activity. So when a part of the brain dies in a stroke, then you will have an area surrounding it where the brain may show increased electrical activity. Similarly, if you have a brain tumor, of course, there are chemicals that can result in epileptic increased electrical activity of the brain, like drugs, addictive drugs, or alcohol. A brain infection, because of the fever and because of the toxins of bacteria, they might result in increased electrical activity. Severe head injury, because it shakes the brain and changes the composition of the cerebrospinal fluid momentarily, or because the severe head injury might have caused cerebral hemorrhage inside the brain. And of course, if during birth there is lack of oxygen. And even after birth, if you have been exposed to a period of rather long period of deprivation of oxygen or deprivation of glucose, so it's hypoxemia and hypoglycemia, then you might be affected. For example, during severe attacks of hypoglycemia, like a diabetic patient who took an overdose of insulin, for example, he might suffer from an epileptic attack, or a person who is in severe oxygen deprivation for a reason or another might suffer from an epileptic attack. The epilepsy does not have a specific age at which it starts, and it affects everyone, males and females, and all ethnic groups. There is often no loss of consciousness. Yeah, I'm not totally okay with this, because if it is major, if it is grand mal epilepsy, a tonic-clonic seizure, it's usually associated with loss of consciousness. So yes, often there is no loss of consciousness. It's not the majority of patients, but some patients, yes, there is often. So I agree. I'm sorry. There is often the word often here is important. So in the majority of cases, we don't have, but in some of the patients, especially in grand mal epilepsy, when the condition is very severe, we have loss of consciousness. Grand mal epilepsy is usually characterized by tonic-clonic seizures. Tonic means that the muscles will be stiffened, and clonic means that there will be jerks or sudden twitching contractions. Of course, the word grand mal epilepsy is an old nomenclature, and it is the most dramatic type because, as I told you before, why is it dangerous? Why is it more dangerous than petit mal epilepsy? Because it might, first of all, these tonic-clonic seizures might result in the patient falling into a swimming pool, for example, or falling onto a cooker with fire. And of course, this might be dangerous. So the tonic-clonic seizures themselves, even without loss of consciousness, might throw the patient in a different position and expose them to risk. The risk, of course, is doubled if there is loss of consciousness. Of course, sometimes they bite their tongues because of clenching of the teeth by tonic-clonic contractions of the muscles of the cheek and the lips. And of course, in some cases of tonic-clonic seizures, there is loss of bladder control. The patient might urinate involuntarily during the attack. In minor epilepsy or petit mal epilepsy, it's just like a temporary confusion or a temporary absence, inattentiveness, minor jerks of the face. I don't think they're written on the slides, but what we have here are the warning signs. So what is aura? Aura is the warning sign. And every patient has more or less specific aura. And the aura is important. Why is the aura important? Because it signals the patient that there is a danger. It warns the patient and the family. And of course, the warning signs are like, they're very similar to petit mal epilepsy, a very short, brief period of inattentiveness. You might be asking yourself, so how is it an aura if it is petit mal epilepsy? Of course, if you don't have tonic-clonic seizures and you have never experienced grand mal epilepsy, then inattentiveness, daydreaming, and spacing out, if they stop here every time, then you have never experienced grand mal epilepsy. But if you have experienced grand mal epilepsy before, and then following the attack after a month or more, you suffer from inattentiveness or daydreaming or spacing out, and this is repeated every time before the major epileptic attack, then this is an aura. So when do we say that it is a warning sign or an aura for major epilepsy? When it is repeated every time and consistently before the attack. Sometimes the aura is a psychic symptom, a feeling of out of body or feeling that you are not inside your body or out of space or out of time. These dissociation feelings are very strange and are very difficult to describe, but they are mentioned by the patients who experience that. An EEG is not definitive, sorry. An EEG is the main tool that we utilize. And an EEG, as you know, is an electroencephalogram, and it traces the electrical activity of the brain. Just like we said in myocardial infarction, in between the attack, the ECG might be normal. Here, in between epileptic attacks, usually the EEG is normal. Maybe it's not 100% normal, but it needs a specialist who is highly experienced to detect those very subtle minor abnormalities. So again, during the attack, what happens? We have spikes, very tall, bizarre spikes of increased electrical activity of the brain that are well known to neurologists and that indicate epilepsy. In between the attacks, the EEG is completely normal or almost normal. So important to know that a normal EEG is not exclusive of epilepsy, or does not mean that the patient does not have epilepsy, especially if there is a history of convulsions or abnormal body movements. There are certain types of bread that increase the frequency of the attacks, and you have examples of them here. Non-whole grain cereals, but on the other hand, whole grain cereals are important to the patient. Of course, as you know, the food to be avoided is refined sugars, refined flour, refined carbohydrates in general. I mean, those carbohydrates that have a high sugar content, and that's why overripe fruits are contraindicated. Transient ischemic attacks are very transient periods of diminished blood supply to the brain or diminished oxygen supply to the brain. And that's why we say broadly that they are periods of relative ischemia to the brain. And relative ischemia means that there is blood flow to the brain, but that blood flow does not cope with the needs of the brain cells, is less than the needs of the brain cell. And if the blood is relatively deficient, less than the needs of your brain cells, then the brain cells do not receive enough glucose and oxygen, do not receive enough energy, or do not produce enough energy, and therefore the brain function is affected. What's the major cause of a transient ischemic attack? The deposition of bad cholesterol on the inner endothelium of the blood capillaries of the brain, or the blood vessels of the brain in general. And when these cholesterol deposits or atheromas or atheromatous plaques are deposited on the inner side, they do two harmful things. First of all, they diminish the diameter of the artery, and therefore they diminish the blood flow. And second, they are deposited like fish scales, and therefore they are harsh, they are rough, they cause injury to the platelets. And when the platelets are injured, they release ADP, or adenosine diphosphate, and this ADP helps stickiness of the platelets. When the platelets are stuck together, they form a nucleus for more cells and cells, red blood cells, fibrin threads, protein molecules to deposit on them and to form a clot. When a full clot is formed, when there is full obstruction, we are no more talking about a transient ischemic attack, but about a blood clot and a brain infarction and a brain stroke. Of course, the warning signs are important because they warn you that there is something wrong going inside your brain circulation. And you have all these warning symptoms and signs that might be sensory, like numbness, like confusion, like dizziness, but they might also be motor, like weakness of a muscle of the face or a muscle of the limb, like trouble articulation and speaking, like double vision because of the extraocular muscles, like difficulty walking or unsteadiness during walking. Of course, if you have any of these, then you have to rush to take aspirin as an antiplatelet drug. But aspirin is the mechanism of action of aspirin is that it is an antiplatelet drug. It prevents a sticking of the platelets together, and therefore it prevents formation of a clot. And this is through inhibition of certain enzymes that help this process. And the same applies to dipyridamole. But clopidogrel, which is a more recent medication, is also an antiplatelet drug that prevents accumulation or adherence of the platelets together, but it works through another mechanism, which is blocking the receptors of ADP, because I said before that ADP makes the platelets sticky, but it needs to bind with receptors, and these receptors are blocked by clopidogrel. If you have a brain stroke, meaning that there is a clot that completely obstructs your blood vessel, then the territory or the wedge-shaped area of the brain that is supplied by this artery will be dead. And as you know, mature neurons do not divide and do not regenerate themselves. Of course, the extent of the stroke and therefore the extent of the lesion will depend, and the symptoms will depend upon the artery that has been blocked. Is it a small artery or is it a large artery? Even after having a brain stroke, you should take antiplatelet drugs, but we also take anticoagulants that are something different, and anticoagulants are drugs that inhibit the plasma proteins that are necessary for coagulation of blood. So the anticoagulant drugs are more powerful, and they have nothing to do with the antiplatelet drugs, but both the antiplatelet and the anti-clotting do not remove the original clot, but they prevent extension of the clot. So how is the clot removed? We cannot in the brain give a medication that dissolves the clot, but the body, our human body, knows how to recanalize the clot itself on its own, but it takes time, and that's why you first give or prescribe antiplatelets or anticoagulants to diminish the extension of the clot if there is a clot. But in case of transient ischemic attacks, you give them as a prophylaxis against another attack and also to prevent extension of the clot. But the improvement that occurs because of recanalization of the clot. A mental disease is a mental health disorder that is, of course, neurological and that seriously affects your mood or thinking or behavior, and that lasts for a long period of time and interferes with normal life. So it's not only about waking up in the morning depressed, it's about a mood disorder that lasts for a long period of time. It's not only about being confused at the end of the day because you didn't sleep enough the past day, but it is a thinking disorder that lasts for a long period of time. It's not only about an aggressive behavior that you exhibited on one occasion. It's about a disturbed behavior that lasts for a long period of time, months and even years, and that interferes with your normal life unless you are treated. Of course, there are examples of mental illnesses here, like depression and anxiety. Depression and anxiety are two opposite disorders because although they might sometimes be present in the same person, um, you might have periods of depression when brain function is depressed and when you are withdrawn from normal life. You live in a bubble, as we say. You do not want to do any of the previous habitual acts that you used to do. You don't want to socialize. You don't answer your phone. You don't do the tasks, whether homework or your job. You leave your job. All these are or you get separated, husbands and wives, and so on. This is depression. But anxiety is something different. As you know, to be anxious is more like being highly irritable and always worried about possible problems and the future. Of course, I'm not a psychologist and we are not discussing this in detail, but what I am concerned with is schizophrenia, because one of the major aspects of it is the bipolar disorder, in which there are periods of illusions and periods of depression. So that's why we call it a bipolar condition. And eating disorders that might be anorexia nervosa, in which the patient does not have any appetite. And we have, on the other hand, bulimia nervosa. And in bulimia nervosa, the patient eats a lot and then induces vomiting in order to lose weight. And you have, of course, the addictive behavior. It is thought that addictive behaviors are related to mental diseases and they lead to mental diseases because people who are addicts to certain medications, especially certain types, sorry, not medications, certain types of drugs, they end up by having mental diseases. They end up by having, of course, a disturbed mood, especially if the drug is withdrawn. Their ability to think and make decisions deteriorates dramatically, and their behavior becomes either very depressive behavior or very aggressive behavior, and they start representing a threat to their community. They might steal, for example, they might kill, and they might have many kinds of abnormal behavior because the addictive drug, especially certain types of addictive drugs, has caused serious changes in their mental powers. Coming back to anxiety, anxiety is different from fear because when you fear something, usually you fear something that is present in the present, but anxiety is usually that you anticipate fear and you anticipate bad events or dreadful events and you're worried about them. I'll stop here and we will be continuing our discussion of the nervous system on the next periods, inshallah. Bye.